Hello, fellow colleagues. This is Edgar Ochoa, physician with the Southern California Permanente Medical Group. Many of you may be familiar with the subject of plant-based diets. Some of you I know are expert in the matter. Unfortunately for me, this is still relatively new, as I've only adopted this way of eating in the last 12 months. To dare try to introduce this complex subject to any of you, therefore, may be presumptuous on my part. But I would like to clarify that what I'm presenting is from the perspective of someone who's practiced primary care medicine for the last 20 years without being formally introduced to the subject. Let me start by making some observations. Anyone who has read major published guidelines for chronic disease is aware of the seeming marked emphasis on the importance of lifestyle changes in these writings. That said, practical or formal instruction on what constitutes these changes is generally lacking. The focus, however, in many evidence-based guidelines in chronic disease management is the use of pharmaceuticals. In a sense, I will admit to having acquired a comfort level with the idea that most of my role in the management of hypertension and diabetes, for example, is just to find the correct pharmaceutical combination or to titrate such treatment with the aim of improving markers for accepted control. Time limitations and day-to-day encounters are perhaps part of what makes this the natural focus of our management. It has been my experience that many patients who begin therapy for a condition acquire over time more complex multi-drug regimens, and that despite such efforts they go on to acquire serious complications of their illness over time. There exists the assumption for some of us that once a patient has acquired certain conditions, we should expect that he or she will have to live with their disease for the rest of their life. Sometimes, however, and I'm sure many of you will have experienced the same, we see patients who markedly improve an uncontrolled condition such as diabetes, an accomplishment which we understand could only have occurred on the part of the patient's own lifestyle changes. So that which we made such serious efforts to control and consequently discovered to our disappointment could not be substantially improved is suddenly made better by the patient's intervention. The reason for such success in some cases can be attributed directly to dietary and other lifestyle changes. As I began to learn more about this subject, I swear I felt sometimes like tearing my hair out, thinking, why don't I already know this information? Well, with that said, let me introduce you to the subject of plant-based diets. Again, from the perspective of a novice, trying to apply what I now know to my practice. For me, it will have to be better late than never. Whole food, plant-based. This term was popularized by Dr. Colin Campbell, PhD, a biochemist, researcher, and nutrition expert out of Cornell University. His story is told in the book entitled The China Study, published in 2005, and also in the movie entitled Forks Over Knives that is now nearly a decade old, that came out in 2011. The studies that were featured early at the outset of both the book and the movie addressed cancer risk in populations of rodents that were exposed to a carcinogen called aflatoxin. Two groups were followed that differed only by the amount of milk protein, or casein, that they were fed. One group received 20% casein, the other group 5%. None of the animals that received the 5% casein diet developed hepatomas. All of the other rodents fed the 20% casein diet, however, developed cancer. So the question arose, could animal protein also raise risk of cancer in humans? This hypothesis is explored further in both the book and the movie mentioned above. So what does this diet consist of? It is made up of plant food, that is, legumes, grains, fruits, and vegetables. It eliminates or reduces processed food, like refined grains, where the micronutrients, phytonutrients, and fiber are stripped away. It's generally low in fat and eliminates or reduces the use of oil. So what are the benefits? At least in observational studies, it reduces the risk of cancer. In addition, it improves and reduces the risk of a multitude of other chronic disease, including heart disease, stroke, hypertension, diabetes, high cholesterol, obesity, osteoporosis, kidney disease, retinal problems. These studies are of various designs, including prospective randomized case-controlled types. A partial list of grains would include oatmeal, corn, brown rice, wild rice, barley, quinoa, rye, bulgur, and farro. How about the legumes? These include beans of all types, peas, including semi-processed varieties such as tofu and tempeh, chickpeas, garbanzos, split peas, and lentils. You will notice the similarities with the USDA illustration called MyPlate. The major difference, of course, is that a plant-based diet contains no animal products, including no dairy or eggs. So let me ask you a question. Do you think it's possible to cure diabetes? Well, my first encounter with the phenomenon was February of 2018. My 58-year-old Hispanic male, who weighed 226 pounds with a body mass index of 35.4, had a maternal history of diabetes, and he came in with 2 weeks' history of what's typical: polydipsia, polyuria, and severe fatigue. His random sugar at that time was 490. So after meeting criteria for starting insulin, I began the patient on metformin and NPH insulin. So after having experienced this diagnosis, which must have been a shock to my patient, he decided he was going to change his diet. Early on, he didn't tell me what he was doing, and what he was consuming was basically plant food, and he was consuming it in smoothie form. So later on, we talked about the changes he had made, and in about 9 weeks, he had to stop all insulin. In less than 6 months, he had to stop all of his medications. His A1C on cessation of everything was 5.3%, and he accomplished in the process a 32-pound weight loss over 6 months. So at the beginning of my journey, learning more about this information, of course I had to look into whether or not this had happened before. And of course it had. In 2013, the Permanente Journal published a case report of a cure of type 2 diabetes in a patient who had adopted a whole food plant-based diet. So at about mid-2019, I had a discussion with Dr. Jonathan Greer, who was my former senior resident, and he informed me that lifestyle medicine included among its principles the use of a whole food plant-based diet, and that in his best case, his best responder was an elderly paraplegic male with type 2 diabetes who within weeks he was able to stop all medication for diabetes, including insulin. So, having reflected on this type of information, my patient's case, this publication, Dr. Greer's information, I decided to adopt this way of eating on July 4th, 2019. So let's look at a brief history of the use of this diet, now again from my own perspective of discovery. So in 1983, Dr. Colin Campbell publishes the China-Cornell-Oxford Project, which is an observational study involving 6,500 persons in rural China. Now, the associations identified in this epidemiological study between diet and disease are discussed at length in the book that I mentioned was entitled The China Study, published in 2005. Then in 1985, Dr. Caldwell Esselstyn published a small trial demonstrating that it was possible to halt the progression of coronary atherosclerosis in patients with established heart disease, and remarkably, a third of the patients demonstrated reversal of their obstructions on coronary angiography. The illustration demonstrates the left anterior coronary artery of a patient that's actually featured in the movie Forks Over Knives, who happens to be a physician. And what you see is the interval of 32 months, demonstrating a before and after picture. Amazing. So in 1998, Dr. Dean Ornish publishes the Lifestyle Heart Trial in the Journal of the American Medical Association. This trial originally was a year, but then was extended for an additional 4 years. At 5 years, the number of patients who completed the study in the treatment arm were 20, with 15 controls. Now, with an average approximate diameter stenosis of about 40% in both groups, you see that in the treatment group, the average reduction in stenosis was 3.1%, whereas compared to the observational group, they got worse by 11.8% in 5 years. So it seems to me intuitive to think that, well, the older a person is, the more diseased they are, the worse they will do. But as it turns out, what actually predicted response was just the adherence to the dietary recommendations. In addition, the control group had more than double the number of cardiac events at the 5-year mark. That said, also remarkable was the fact that the observed benefit was achieved without the use of statins. So what are the implications of the Lifestyle Heart Trial on the use of statins? So recall that the treatment group did not receive any. On the other hand, the control group did, and did also follow some lifestyle changes, including exercise on an average of 3.5 times a week and a 25% reduction in calories from fat. However, despite that group following conventional care, they demonstrated this progression of stenosis, as we saw in the previous illustration. If you looked, however, at just the control group, and you made a comparison between the ones who were and were not taking their statins, the disease progression by diameter stenosis was 3 times greater in those who didn't take their medication. So in summary, we can see that the treatment group, without the use of statins, demonstrated a regression of disease in some cases, and at the very least a cessation of the worsening of their disease. The authors noted that perhaps the difference would have been even greater had they retained 4 of the lesions, the coronary lesions that they lost to follow-up in the observational group, as these individuals had to undergo bypass or stents. Finally, it can be said that following dietary measures, of course, is fantastic. However, if you are unable or unwilling to do so, it is of absolute importance for you to take your medications. In 2005, Dr. Dean Ornish published a trial involving 93 men with early-stage biopsy-proven prostate cancer. So the same type of lifestyle changes that were undertaken in the Lifestyle Heart Trial were also undertaken here for these men with prostate cancer. In the treatment group, there was a reduction of the PSA levels by 4%, as compared to a rise of 6% in the control group. In addition, in vitro cancer growth suppression against prostate cancer cell lines, this being determined by a measurement of cell apoptosis, was 8 times greater in the treatment group. At the end of the 1-year study, 6 of the patients in the control group went on to require conventional, more definitive treatment for their prostate cancer, but none of the patients in the treatment group required this. In 2006, Dr. Neil Barnard published a trial comparing the ADA diet versus a vegan diet in Diabetes Care, which is the journal of the ADA. So this study looked at patients with type 2 diabetes. 49 who were in the treatment group were given a low-fat vegan diet, which consisted of 10% calories from fat, 15% from protein, and 70% carbohydrate. The 50 controls were recommended to the ADA diet. Most of the patients, with the exception of 3, had a body mass index that was over 25. Therefore, both of the groups were given instruction on how to achieve a 1,000 to 1,500 calorie deficit. The study required a sub-analysis of so-called medication-stable patients, and this represented the group of patients who, after the 22-week period, had not had any changes in their initial medical therapy. Both groups of patients required adjustments, however, in their treatment due to hypoglycemia. So what were the results? The following compares the vegan versus the ADA groups, looking at all of the participants versus the subgroup of medication-stable patients. Both of the diets achieved weight and A1C reduction, however, the vegan diet was superior. This graph demonstrates the response of the patients over a 22-week time period. Illustrated in red is the ADA group, and you see how they seem to stabilize their A1C over time. And that's compared to the vegan group, where they continually demonstrate an improvement of their A1C. And finally, the greatest disparity illustrated is that in the medication-stable patients, as shown by the solid square versus the solid blue circle. So let's take a look backward. In the 1970s, there was the Pritikin diet. The first time I heard the name Pritikin was in my first year of medical school. As you all know, the first 2 years are all academic, mostly classroom, work, and anatomy lab. We had, however, a mini elective option where the students learned to check one another's blood pressure. In this context, it was mentioned that some people in rural settings in foreign countries were little impacted or not at all affected by such things as cardiovascular disease or hypertension. Well, that was the last I heard about Nathan Pritikin until 2019. Many of his lectures are available on YouTube. As an aside, the first mention of studies that Pritikin discussed relevant to the matter of insulin resistance were undertaken in the 1920s, and we'll touch on this soon. Earlier than this, in the 1940s, Dr. Walter Kempner out of Duke University treated people with the so-called rice diet. He was treating individuals with malignant hypertension with a diet of rice and fruit. 70% of the patients that he treated normalized their blood pressure, and several of them in the process of their treatment recovered from diabetes, heart failure, renal disease, and their retinal disease. A reduced calorie version of this program was able to reduce weight in excess of 100 pounds in many morbidly obese patients. So here's a question. Is dietary fat a more important determinant of diabetes than carbohydrates? Well, in 1927, Dr. Shirley Sweeney published a study where healthy medical students were made to eat fat or protein or carbohydrates, or were made to fast for 48 hours. After this period of time, they were given a glucose tolerance test. So what were the results? The sugar group had a normal response. All of the other groups tested developed much higher values of blood glucose. So what was the lesson? Dietary fat rather than carbohydrates was beginning to be recognized as a causal factor in insulin resistance. So how counterintuitive is that? Eating sugar registers a normal result on a glucose tolerance test versus all of these other groups? And how is it that eating fat versus fasting registers a similar rise in glucose levels? Well, an explanation sort of goes like this. As we are fasting, we start to utilize our glycogen within our liver and our muscles, and after we deplete this, we begin to cannibalize our own fat stores. It's in this sense that someone who's fasting is a little bit like someone who's eating fat, except that person is eating their own fat stores. So is fasting bad for you? Fasting has been used with success to treat insulin resistance, in part by reducing weight and decreasing total body fat. and various forms of fasting have been used with success in treating diabetes of all types. And this is discussed in a lot of detail by Cyrus Khambatta, PhD, and Robbie Barbaro in their book called Mastering Diabetes. So what the health? Actually, that's the title of a movie produced in 2017 by Joaquin Phoenix. But seriously, I had to ask myself, why haven't I heard this before? How is it that information like this isn't an integral part of customary medical practice? Certainly not of my own practice, unfortunately. So, as I mentioned earlier, there's a lack of instruction in medical school training, and I could certainly attest that that was the case for my generation, apparently, or at least for my medical school. Much of what we read after graduation that is evidence-based is focused on pharmaceuticals, medical procedures, and devices. Lastly is the matter of reimbursement. The Ornish Reversal Program that was developed by Dr. Dean Ornish, who is the same author as the Lifestyle Heart Trial, notice that this program didn't garner any significant adoption until Medicare and other insurance companies began to pay for the program. So let me make an effort at a synopsis of sort of the major points that are, for me, takeaways. Number one, the role of dietary fat versus carbohydrates on diabetes. So now there's been nearly a century of information on the effect of diet on glucose levels and diabetes. This information explains the unexpected reversal of diabetes in some patients who are eating plant-based diets, often with a relatively high percentage of total dietary calories from carbohydrates, up to 70%. Number two, food versus medication. For patients with chronic disease, dietary choices are often a much more important determinant of health than the use of medications. And this, of course, would be qualified by certain exceptions. For instance, diabetics who are incapable of producing insulin. In type 2 patients, this can be determined in part by measuring levels of C-peptide. And what about the Lifestyle Heart Trial? When you looked at the control group, how much worse did those individuals fare who did not take their statins in that subgroup? The third, taking food for granted. Something so basic and easily disregarded as food is able not merely to prevent disease, but also to improve or reverse chronic diseases. So in summary, addressing particularly my colleagues in SCPMG, I would just like to make the observation that what's good for our patients is good for our organization. Being able to see people succeed in managing their chronic conditions is also good for our personal practice. It improves our morale as we see people sometimes making radical improvements in their conditions. It gives us the satisfaction that we can do more than mitigate harm. We can always practice in accordance to our training, having some assurance that we are making a difference. Putting the focus on lifestyle changes as primary, however, with the addition of medical therapy as adjunctive, may yield the best outcome, at least in some patients. Who can say what the effect might have been in the Lifestyle Heart Trial, for example, if the treatment group had been allowed to take statins? Indeed, we might even see the reversal of chronic disease with non-pharmacologic measures alone. I would love to see a transformation in the health of people suffering with chronic disease. From what I have now understood, it seems that a path to such a transformation has been identified. It is challenging to incorporate this knowledge into our practice given the time constraints integral to our access demands and our schedules. Ours is, however, only one part of a larger healthcare system. It seems to me that there is great potential in case management and community-based patient education. So what do you think? I invite you to consider further the resources that we've discussed, the original articles, My hope is to spread awareness amongst physicians and other healthcare professionals on the subject matter we've addressed today. Just think what we could do together if all of us incorporated these principles into our practice. What could we really do? Anyhow, thank you so much. Thank you so much for your patience and for your consideration.
What's up?
I'm sorry, he's talking to me.
You gotta get this malpractice on film so I can sue him, you know?
Everything come out okay, Doc?
He's got about a day to live.
Did the light shine through?
Yeah, I went through. He's chained on the door over there. And we all over here.
Oh, I can't hear you.
Come on, man.
What?
Easy!
Oh, let me do the scratch test.
I ain't scratching.
Don't go scratch me. Get out of here.